Okay, folks, thanks for coming. So I was speaking with my 14-year-old niece last week, and you know, she's like any niece. She thinks she's really hip, and she's surgically attached to her iPhone. But in a rare moment of recognizing the outside world, she asked me what I was working on. And once I picked myself up off the floor, I told her that I'm presenting next week, and I've been working on that, and it's very important that we present to the public and try and get the results of our work out there. And she said, well, I think you should rock their worlds. That's not going to happen, but I hope the next 2 hours are engaging. So this is what I hope to cover very briefly in the course of my 15 minutes of fame. So I'm going to talk very briefly about the burden of mental health, and in particular depression, because why else would we be here if it wasn't important and exacting a significant public health burden. I'll then segue very quickly to the consequences, treatment, risk factors, but my main focus is, as the title suggests, on adverse childhood experiences, and I'll build into that some research we're currently doing, so unpublished as yet, from a longitudinal study in the UK, and I'll finish inevitably with some conclusions. So this is a pie chart, and it's the burden of non-communicable diseases worldwide. So non-communicable diseases exclude diseases like tuberculosis and HIV, but do include the obvious suspects like cancer, cardiovascular disease, respiratory disease. Cardiovascular disease should not be 2%, it should be 20%. It's not my slide. But what you'll see is that psychiatric disorders, more than 25% of all 25% of the burden of non-communicable disease is occupied by that particular cause. So, and psychiatric disorder is broken down to a bunch of different psychiatric entities, as you'll all be aware, and you'll heard of some of these: epilepsy, for instance, dementia, but by far the most commonly occurring is what's called in this academic article unipolar affective disorder, which you can think of being serious depression. But overall, there is clearly no health without mental health. And if you take these percentages and you convert them, about 500 million people throughout the world are suffering from some form of the mental health problems depicted. And just like hypertension, just like diabetes, depression is an important disease in its own right, but it also comes at a myriad consequences. So various problems, consequences, outcomes of depression include negative impact on relationships, which may manifest themselves in personal relationships or work relationships, sleeping problems, addiction, appetite loss, which can lead to weight loss. But importantly also, mental health has a known impact now, I think it's fairly safe to say, on physical health. And these are data from some work we've done looking at psychological distress. So psychological distress includes depression, but also includes anxiety. And one of the reasons we put them together in one pot is because rarely does one exist without the other. And as such, treatments are similar. But someone who is depressed will often exhibit symptoms of anxiety as well. And this is a general population-based survey of around 150,000 people, and they were followed up over time for the occurrence of suicide. And what we find is that the more severe the distress, the greater the risk of suicide, increasing distress risk here, increasing mortality risk here. And it seems to be stepwise across the full range, so individuals who are moderately depressed still have an increased risk of suicide. What's also important to say at this stage is in our study and in all other studies, there seems to be the case that if you take individuals who died from suicide, it's actual fact the minority of those individuals that have a mental health problem. So the classic statistics are in people who have taken their own life, around 50% have a mental health problem across the life course, and less than that, about 30% in the last year. So while mental health is important for suicide risk, it's not the only risk factor by any means, but it's probably the most powerful. And this probably doesn't come as a great surprise to you that depression, more broadly defined, is associated with suicide risk, but what's emerging in recent years is that psychological distress is also associated with cardiovascular disease and other non-communicable diseases like cancer. So this is a similar slide with cardiovascular disease as the outcome of interest. And again, you see this stepwise association such that individuals who have greater levels of depression, these are individuals in the community. Many of these aren't undergoing any kind of treatment, talk therapy or drug therapy, and yet they have an increased risk of cardiovascular disease. And we don't really know why that is. It's probably partly because people with mental health problems typically don't look after themselves very well, so they sometimes have higher rates of smoking and heavy alcohol consumption than the general population. They tend to be more sedentary. It's also the case that some anxiety-type disorders may lead to an elevation in blood pressure, momentary elevation in blood pressure, and we know blood pressure causes cardiovascular disease. It's also the case that some medications may increase your risk of cardiovascular disease, but it's not fully understood. Good news is that if I was giving you, if this was a slide for the treatment of dementia, it would be blank. So because treatments for dementia are largely ineffective, they don't exist. There's some evidence there are treatments for treating some of the symptoms, but we can't slow the decline from cognitive impairment into dementia. But treatments for depression are really very good. And these could be talk therapies, such as cognitive behavioral therapy, where we tend to try to, or colleagues tend to realign negative thinking into more positive thinking, and also drug therapies, antidepressant medication, anxiolytic medication, that is anxiety-lowering medications, have shown great efficacy, particularly in folk who are very severely depressed. Obvious examples would be selective serotonin reuptake inhibitors. However, as any drug, whether it's aspirin, whether it's antibiotics, not everyone responds positively to them. So about 50% of folk are treatment resistant, so they're not going to get better on either talk therapies or drug therapies. So that brings into sharp focus a lot of what we're going to be talking about today, which is a need to prevent depression. So looking at primary risk factors so depression doesn't happen in the first place. And known risk factors, at least in observational type research, there's not good trial evidence as yet, and there may never be in this area, but known risk factors in middle-aged and older adults include socioeconomic factors like poverty and unemployment, death of a loved one, relationship breakdown, physical illness. We know individuals with a diagnosis of diabetes, cancer, cardiovascular disease have an elevated risk of mental health problems. There's also parental depression, which is a proxy for some genetic factors, and also interestingly, not if you're a woman perhaps, but it's interesting that from an epidemiological perspective, that there is a much higher prevalence of mental health problems, particularly depression in women relative to men. That might be real. It may be that also, as many of the men in the room will recognize, women are just better talking about their feelings. They're more likely to report their symptoms than men. It's unclear. However, these factors, when measured in middle and older age, don't fully explain the occurrence of depression. So that's led us, the royal us, to look at factors measured at other points in the lifespan, including childhood, in a very kind of Freudian manner almost, looking at the influence of childhood on later life depression. And one of the factors that's received a lot of attention recently is adverse childhood experiences. Obviously, there's an abbreviation for everything now, and this has its own. But there's quite a lot of work at the Centers for Disease Control in Atlanta in this area. And it's broadly defined as traumatic events in childhood, unsurprisingly. But not only trauma, it can just be a failure to provide a safe, stable, and bonding environment for a child. And if we're increasing severity, if I was to define it with increasing severity from left to right, this end of the scale, the less severe end of the scale, you might have lower socioeconomic position, financial hardship, poor nutrition, in themselves not unimportant, but moving through to the really severe end of the scale, physical, psychological, sexual abuse, some of which are in the descriptions of the artwork outside. Some of these adversities are referenced in some of the descriptions outside by the artists, and including loss of family member, loss of parent, including loss of parent. But what I'm going to do today is I'm going to focus on our out-of-home care of these particular indicators of adverse childhood experience. Out-of-home care means a child goes into the care of the state. So that's because there is failure within the family to provide this safe, stable environment. And present day out-of-home care typically means foster care. Historically, it could have meant foster care. It could also have meant going into a children's home, but they tend to not exist in the same way these days. And certainly in the UK and also in the US, there's been an increase in recent years in the number of kids going into care. And the CDC has outlined a number of linkages between adverse childhood experiences and health outcomes, life outcomes, not just health outcomes, life outcomes in adulthood. And these range from traumatic events through to unwanted pregnancy and complications with that pregnancy, sexually transmitted infections, including HIV, cancer and diabetes. But I'm going to focus on socioeconomic outcomes of childhood adversity, alcohol and drug abuse, and of course, why we're here today, some mental health problems. And I'm going to do this using the UK National Child and Development Study, which is a longitudinal study, longitudinal because it occurs over a long period of time, of individuals who were born in 1958. And of course, last year celebrated their 60th birthday, hooray. And we and others, I wasn't around at the start, have been involved in surveying these individuals over many years. And there have actually been 11 surveys to date, starting in 1958, of course, through childhood. And next year we go into the field with a biomedical survey. But we've captured information on whether or not the child was in care, which was reported by the carer or the parent in early life, and then we followed them up over this period. And at age 42, we collected a series of adult outcomes. And I'm going to show you the evidence today that link out-of-home care, this marker of adversity, with childhood outcomes, adult outcomes. And so this is looking at whether or not an individual was in care and their socioeconomic markers in later life. And what we see is that if a child had a history of care in adulthood, at age 42, they were more likely to be in a low prestige job, a manual job. They were more likely to be unemployed. The orange is individuals in public care. They were more likely to be homeless, but this isn't a great cohort for looking at homelessness. Rates are very low. They were they're more likely to have a basic education, and they're also more likely to have called on welfare services for financial support. Thinking more about health outcomes and a history of childhood care, again, we see it's unfavorable outcomes in adults who as children were in care. So in general, they had poorer physical and mental health. But looking specifically at mental health, there's a greater likelihood of them to report depressive symptoms in adulthood, and a greater likelihood that they have seen a health professional, whether it be a psychiatrist or other health professional for care. And they're also more likely to be smokers and report problems of alcohol consumptions, which may be a consequence of their greater psychiatric burden. And lastly, just in criminal behaviour and deviance behaviour, there tends to be a higher prevalence of criminality and illicit drug use in later life amongst kids who have been in care. So we've looked at those relationships. They seem to exist. what can we do about it? Well, this is guidance again from CDC, and the guidance, which isn't yet evidence-based, at least not much of it, calls on quite obviously to focus on parenting and also school environments, the environments in which children exist. And to pick out a couple from here, there's a focus on preschool learning and a focus on enhancing parenting skills to promote a healthy environment for a child, as well as a more established welfare system to provide economic support for those families. Okay, so just to conclude then, depression is common, it's burdensome, it has very well-known negative outcomes that aren't just health-related, but are in the social spheres and socioeconomic spheres. Treatments are effective, but not universally so, and that's why we're here today to consider primary prevention. And we know that there are many risk factors, at least from observational work, and including early life, where, to my mind, there should be more focus on understanding the etiology of later life depression. There we go.